Hi all, welcome to the next class of Assistant Surgeon Kerala PSC exam. This is module 10 and the subject is dermatology. The good thing about learning dermatology is that it can fetch you 4 to 6 mark if you learn dermatology within 10 minutes for revision and within 35 minutes of a long class. You will be able to crack those 4 to 6 mark within little amount of time. So straight away into the class, psoriasis in Kerala PSC question paper, surely there will be a question from psoriasis. So, into the class. Psoriasis is a chronic immune mediated papulosquamous disorder with erythematous, sharply demarcated lesions. It can affect both sexes, and the peak onset is from 15 to 30 years of age. Etiology: it is a T cell mediated disease, HLA CW6 genetic association, and the triggers for psoriasis are trauma, streptococcal infection, stress, drugs like beta blockers, lithium. Clinical features: the patient will present with a well demarcated erythematous plaques with silvery scales. Sites: mainly it will be on elbows, knees, scalp, and lumbosacral region. Auspitz sign is positive and Koebner phenomena is positive. What is Auspitz sign? There will be pinpoint bleeding on scraping. What is Koebner phenomenon? On the line of trauma, the disease will reappear. Okay. What are the nail changes in psoriasis? It's spitting, onycholysis, oil drop sign, out of which oil drop sign is the most specific sign. The variants are guttate psoriasis, pustular psoriasis, erythrodermic psoriasis, and flexural psoriasis. What will be in the histopathology? In histopathology, there will be parakeratosis, acanthosis, reti ridges will be elongated, thin to suprapapillary plates, Monroe abscesses. Monroe abscess is a previous year question paper. What are Monroe abscesses? They are neutrophils in stratum corneum. How to remember? Monroe neutrophil, MN, in stratum corneum. There will be spongiform pustule of Kojak. Then the complication is psoriatic arthritis. Psoriatic arthritis is an erosive arthritis. There will be secondary infection, erythroderma, psychosocial morbidity. The treatment is mild topical steroids, calcipotriol, coal tar, salicylic acid, diethranol, and in moderate to severe cases, go for PUA therapy, soralin plus UVA therapy. Systemically, we can give methotrexate. It is the drug of choice in India. Cyclosporin, acitretinib. Biologicals: anti-tumor necrosis factors like etanercept, infliximab, anti-interleukin 17, secukinumab, anti-interleukin 23, ustekinumab. Then important points to be noted is that the drug of choice in systemic psoriasis is methotrexate. Auspitz signs and Koebner sign is positive in psoriasis. Monroe microabscess is the hallmark in histopathology. Guttate psoriasis. The question will be framed as a child after getting infected by streptococcus is presenting with erythematous plaques like that. Then the answer will be guttate psoriasis. Look at the pictures. Auspitz sign, there will be pinpoint bleeding after scraping. The nail psoriasis, remember as polish. So pitting, oil drop sign, onycholysis, leukonychia, irregular pitting pattern, splinter hemorrhage, hyperkeratosis. Okay, this is about psoriasis. Then coming to infections of skin. In it, impetigo. Uh, in previous year question paper, I have seen they have given the clinical features, signs, and symptoms of the disease and have asked us to mark the correct answer. So, impetigo, the patient will present with honey-colored crest in face or extremities. It is caused by streptococcus or staphylococcus. Diagnosis is by clinical, and the treatment is mupirocin or oral antibiotics. Eczema was a previous year question. Ulcerative impetigo is known as eczema. It affects the deeper dermis, so treatment should be oral antibiotics. Then coming to cutaneous TB will present with as lupus vulgaris, scrofulоderma, and the diagnosis is by biopsy and culture, and the treatment is antituberculous therapy. In Staphylococcus scalded skin syndrome, the Nikolsky sign will be positive. In herpes simplex virus infection, Sangsmear will show giant cells. Then the molluscum contagiosum, there will be umbilicated pearly papules and the treatment will be curettage or cryotherapy. In pityriasis versicolor, the patient will present with hypo or hyperpigmented macules, and the diagnosis is by KOH stain. And in that, we will find spaghetti and meatball appearance, and the treatment is selenium sulfide. So, spaghetti and meatball appearance is seen in pityriasis versicolor. Scabies, the patient will present with severe nocturnal pruritus, burrows in finger webs. Okay, the treatment is 5% permethrin and ivermectin. These are the pictures. So coming to chronic dermatitis. Chronic dermatitis, there are various types of chronic dermatitis. First, coming to atopic dermatitis, the patient will have a history of atopy like asthma, allergic rhinitis, and atopic dermatitis. It is known as atopic triad. It is a chronic relapsing eczema with severe pruritus in flexure sites in adult and extensor sites in infants. Lichen simplex chronicus, it is due to repeated scratching. A localized lichenified plaque will be seen, and the sites are nape of neck, ankles, scalp, vulva, or scrotum. Treatment is with topical steroids and antihistamines. Prurigo nodularis, it is intensely itchy nodules on extensor surfaces, and it is associated with atopy, renal or liver diseases, HIV. Treatment is topical steroids and phototherapy. Nummular eczema, it's a coin-shaped itchy plaques, mostly on extremities. The treatment is emollients and topical steroids. Irritant contact dermatitis is non-immunological. Direct irritant is the cause, and the treatment is to avoid the irritant, emollients, and steroids. Allergic contact dermatitis is a type 4 hypersensitivity reaction. The common allergens are nickel, cement, and hair dye. Patch test is diagnostic. Treatment is to avoid allergen and use topical steroids. Seborrheic dermatitis, greasy scales on scalp, eyebrows, chest, and it is associated with Parkinsonism and HIV. Treatment is ketoconazole shampoo or cream and mild steroids. Photosensitivity dermatitis. The patient will present as rash on sun-exposed site, and the causes are drugs like tetracycline thiazides. It can be autoimmune causes such as SLE and porphyrias. Treatment is sun protection and stop the drug. Stasis dermatitis, it is seen in chronic venous insufficiency. It is common in leg and ankles, and there will be brown pigmentation, eczema, ulceration. Treatment is leg elevation, compression stockings, and topical steroids. So, in short, in dermatitis, the mainstay of treatment is to avoid the irritant or contact, emollients, topical steroids. Okay, then coming to next topic, vitiligo. Vitiligo is the acquired depigmentation disorder due to the loss of melanocyte. So, skin will appear white. It is an autoimmune destruction of melanocyte, and it is associated with thyroid disease, diabetes mellitus, pernicious anemia. The patient will present with sharply demarcated depigmented macules, which will be mostly symmetrical, common on face, hands, genitals. On Woodsland examination, there will be accentuates depigmentation. On biopsy, there will be absence of melanocytes. Treatment is topical steroids, mainly tacrolimus, Momet cream, phototherapy, surgical grafting for stable cases. The important points to be noted is that it has an association with other autoimmune diseases. And in it also, Koppner phenomenon is seen. Vitiligo also shows Koppner phenomenon. Coming to leukoplakia, remember that it is a pre-malignant lesion. There will be a white patch or plaque in oral mucosa which cannot be rubbed off. It is a pre-malignant lesion, and white adherent patches will be seen on buccal mucosa, tongue, which is non-scrapable. How can you differentiate it from candida? Candida is scrapable, leukoplakia is non-scrapable. On biopsy, there will be epithelial dysplasia. Treatment is to remove the risk factor, excision, cryotherapy, or laser. Important point is that it will it is it has a malignant transformation risk of about 5 to 10 percentage, especially if it is on tongue and floor of the mouth. Okay. Then coming to lichen planus, civet body is a previous year question paper. Civet body is seen in lichen planus. Definition of lichen planus says it is a chronic inflammatory skin and mucous membrane disease. It is an immune mediated T cell damage due to basal keratinocytes. Which cell is affected? T cell is affected. Okay. Sorry, keratinocyte is affected due to T cell immune mediated T cell damage to basal keratinocytes. Okay, the patient will present with 6 P's: purpule, polygonal, planar, pruritic, papules, plaques. So 6 P's: purple, polygonal, planar, pruritic, papules, plaques, which strium will be becomes strium will be seen in lichen planus, and the sites are flexures, wrist, etc. The lab diagnosis on biopsy, you will see a sore tooth acanthosis and civet bodies will be seen in lichen planus. Treatment is topical steroid, antihistamine, systemic steroids, or retinoids for severe cases. Important point to be noted is that, like Leukoplakia or lichen planus, is also precancerous, and the Gobner phenomenon is seen in lichen planus also. Psoriasis we have covered. Coming to Pemphigus vulgaris, it is an autoimmune intraepidermal blistering disorder. The pathology is that IgG autoantibodies will destroy desmoglin 3. So there will be acantholysis. The clinical feature will be the patient will present with flaccid bulla. It can rupture and cause erosion. In Pemphigus vulgaris, oral mucosal involvement is seen. In Pemphigus foliaceus, there will be no oral mucosal involvement. The Kolke sign is positive. On lab diagnosis, Sang smear will show acantholytic cells. Biopsy will show suprabasal split. Previous year question. Direct immunofluorescence will show intracellular IgG, which is fishnet pattern. So fishnet pattern is seen in Pemphigus vulgaris. The treatment is systemic steroids and immunosuppressants like azathioprine, mycophenolate, and biologicals such as rituximab. It was also a previous year question. Rituximab is used in Pemphigus vulgaris. Okay. The important point is that the most common form is Pemphigus vulgaris itself. It's life-threatening if left untreated. Then coming to leprosy, leprosy is a very important topic. Questions can be there from leprosy. It is a chronic infectious disease which is caused by Mycobacterium leprae. It affects the skin and peripheral nerves and mucous membrane. Ridley Jopling classification, there are tuberculoid leprosy and lepromatous leprosy, and some variants in between. Okay, tuberculoid leprosy, remember, as there will be few patches, they are well defined, anesthetic, and there is strong cell mediated immunity in tuberculoid. In lepromatous leprosy, multiple diffuse lesions will be seen, they will be symmetric, nodules will be there, eyebrow loss will be there, and there will be poor cell mediated immunity in lepromatous leprosy. Then when will we say that the lesions are posibacillary? If there are less than 5 skin lesions, one nerve affected, and smear is negative, and we will tell it as posibacillary leprosy. When will we tell it as multibacillary leprosy? If there are more than 5 lesions, greater than one nerve is involved, and the smear is positive, we will say it as multibacillary leprosy. The cardinal features will be the patient will present with hypopigmented erythematous patches with sensory loss. Remember, skin is affected, nerve is affected, so there will be hypopigmented patches and there will be sensory loss. Thickened peripheral nerves, and demonstration of AFB in slit skin smear is diagnosis. Investigation by slit skin smear. Lepromin test will be positive in tuberculoid leprosy. Why? Cell mediated immunity is more in tuberculoid leprosy. So lepromin test will be positive in tuberculoid leprosy. On biopsy, there will be granulomas in tuberculoid leprosy and foamy macrophages in lepromatous leprosy. Treatment for posibacillary 6 months, and for multibacillary it is 12 months. For posibacillary it is with rifampicin and dapsone, and for multibacillary it is with rifampicin, clofazimine, and dapsone. Then reaction status, some lepra reactions will occur, out of which type 1 lepra reaction is reversible, and the cell mediated immunity is more in type 1 reaction, and there will be erythema of lesion, and the treatment is by steroids. In type 2, it is erythema nodosum leprosum. It is an immune complex mediated reaction. There will be nodules. Then the treatment is thalidomide. Then control program, National Leprosy Eradication Program was started in 1955. Multi-drug therapy was started in 1982, and we have eliminated leprosy as a public health problem in 2005. The strategies are early detection, multi-drug therapy, disability prevention, information education, and communication. Okay, important point, India had the highest global cases. First nerve to be involved is ulnar nerve. The complications are claw hand, foot drop, and lag of thalamus. Then coming to Ridley Jopling classification, I have included this because it has been previously asked. In tuberculoid leprosy, there will be strong cell mediated immunity, there will be asymmetrical nerve involvement. Then in satellite lesions are seen in borderline tubercular lesions, tuberculoid, borderline tubercular Hansen disease. Then in lepromatous leprosy, there will be no cell-mediated immunities. Then coming to Steven Johnson syndrome, previous year question. It's a severe mucocutaneous reaction. There will be epidermal necrosis, detaching involving less than 10% of body surface area. If it is greater than less than 10% of body surface area, it is Steven Johnson syndrome. And it is a type 4 hypersensitivity reaction. Mostly it is drug induced. For example, sulfur drug, anticonvulsants, NSAIDs, and antibiotics. The patient will present with painful skin erosions of greater than or equal to two mucosal sites like oral, ocular, and genital erosions, and the Nikolsky signs will be positive. Then mortality is approximately 5 to 10 percentage. The treatment is to stop offending drug, supportive ICU or burn care, fluid and electrolyte, wound care, steroids, IVIG, cyclosporin in selected cases. And coming to toxic epidermal necrolysis, it is the most severe drug-induced epidermal necrolysis. Greater than 30% of the body surface area is detachment will be there. It is due to cytotoxic T cell mediated reaction. Then the mortality is about 30 to 40 percentage. And Scotland score is used to assess the prognosis. The patient will present with diffuse erythema, confluent epidermal necrosis, sheet-like sloughing. Nikolsky sign will be positive. The treatment is to stop the culprit drug, ICU or burn or ward care. Fluid or electrolytes should be given. Nutritional support should be given. Prevention of infection and IVIG or cyclosporin. Then coming to erythema multiforme. Remember that it will be mostly affected with HSV infection, herpes simplex virus infection. It's an acute immune mediated disorder, usually post infection with HSV. It is a cell mediated immune reaction, and the triggers are HSV, mycoplasma, or any drugs. There will be targeted iris lesions, and acral distribution will be there. Treatment is to treat the cause, like acyclovir for HSV, symptomatic treatment such as antihistamines or topical steroids, and in severe cases, give systemic steroids or IVIG. Then Pemphigus vulgaris, desmoglein 3 is affected. Pemphigus foliaceus, desmoglein 1 is affected. Pemphigus vulgaris, oral involvement is there. Pemphigus foliaceus, there will be no oral involvement. The blister level will be suprabasal in Pemphigus vulgaris. It is subcorneal in Pemphigus foliaceus. Then fishnet IgG and C3 between keratinocyte is seen in Pemphigus vulgaris. Okay. Then the Pemphigus foliaceus type seen in Brazil is known as Foga selvagum. Then coming to bullous pemphigoid, it was a previous year question. The etiology is IgG against BP180 and BP230, which is hemidesmosomes. Okay, hemidesmosomes is the important point to be remembered here. The blister level will be subepidermal. It will mainly affect elderly of greater than 60 years. There will be tense pulla on erythematous or articulated base, and mucosa is rarely involved in bullous pemphigoid. Nikolsky sign is negative in bullous pemphigoid. Linear IgG and C3 along the basement membrane zone will be seen. Treatment is oral steroid, doxycycline, and immunosuppressant. Dermatitis herpetiformis. The question will be framed as a gluten sensitive person. Okay, so um, we should remember that it is associated with celiac disease. Okay, then it is due to IgA deposition at dermal papilla or can be autoimmune. Association with celiac disease, HLA, DQ2 and DQ8. It is also a previous year question. HLA of celiac disease was asked. It is DQ2 bar DQ8. Then there will be grouped vesicles with severe itchings, so it is known as herpetiforms. Main sites are elbow, knees, and buttocks. Neutrophilic microabscesses in dermal papilla will be seen in dermatitis herpetiformis. Neutrophilic microabscesses in dermal papilla. Okay, on direct immunofluorescence, IgA deposits will be seen. Treatment is Dapsone is the drug of choice plus gluten-free diet. Then coming to epidermolysis bullosa. It is a genetic defect in keratin, laminin, and collagen. Epidermis bullosa simplex, keratin will be deficient. Junctional epidermolysis bullosa, laminin, and dystrophic epidermal bullosa is due to collagen 7. Okay, then the patient will present with fragile skin, bulla after minor trauma. Complications are secondary infection and squamous cell carcinoma. Risk is higher in dystrophic epidermolysis bullosa. Treatment is supportive, wound care, and gene therapy trials. Steven Johnson syndrome has already been discussed. Then, coming to dermatological manifestation of internal malignancy, in it, remember necrolysis, thick migratory erythema is seen in glucogonoma, pancreatic islet cell tumor, pyoderma gangrenosum is seen in inflammatory bowel disease, leukemia, and myeloma. Necrobiosis lipodica is seen in diabetes mellitus. Portreous abscess is seen in cutaneous T cell lymphoma. So I will be giving the link of these notes below. So if you want, you can download the notes. And in the notes, I have included Kerala PSC Assistant Surgeon Question Bank based on the topics I have taught you. There are about 50 questions from each topic. So if anyone wants the note, download from the link and solve the question bank also. It will be very useful for you. So I hope the class was good. So I will meet you on next Sunday at 11 a.m. for a next class.